Hello, everybody. My name is Jennifer Okemah. I am a registered dietitian and a certified diabetes care education specialist. I'm here to talk to you today about diabetes devices and tools. And my slides are not advancing. Why they're not advancing. Here we go. So today the objectives we're going to do a timeline review. We're going to cover devices, pumps, CGMs, smart insulin pens, and go over some other tools that are available to people with diabetes. I'm also going to talk about creating your team and discuss uploads and downloads, and then we're going to talk about the elephant in the room. Here's a timeline review. We have the first insulin pen was actually invented in 1954, the first insulin pump in 1964, the first glucometer in 1971, and the first smartphone was an IBM smartphone. And I can't tell what year because my pictures, there we go, in 1995, and the first CGM in 1997. And the reason I bring this up is because technology is in a completely different place than it was way back then, but it takes a long time for things to come to market. And a lot of times we hear things on the media of this new pump or this new CGM, and I have patients come into me and say, I want that right now, and they may not be FDA approved yet, and time to market takes seemingly forever. So we actually have had products for quite a while. They just haven't been either usable or they haven't been on the market in mass production like they are now. So here's kind of an overview of that timeline. This is what the first insulin pen looked like. Doesn't that look ridiculous? Or, I don't know, sort of a steampunk insulin pen. And now we have what we call smart insulin pens, and I'll talk about those in a little bit. This was the first insulin pump. I actually saw this in person. It's in a museum in Northridge, California, and it looks like a jetpack. And insulin pumps were first invented actually for morphine and morphine delivery, and there was just a morphine delivery rate, and some genius said, why aren't we doing insulin that way? So hence the insulin pump. Here's the first glucometer. There were other methods of testing blood sugars, but this was the actual first personal use glucometer, and our transition into small glucometers that can fit in your pocket. There's the first smartphone. This was an IBM smartphone. And it was actually a smartphone. It wasn't a cell phone. It was a computer. And now I'm looking at the iPhone 12 as my next purchase. There's a CGM. I don't know how many of you guys remember the SIL-serter for the iPro. We in the medical community affectionately called it the harpoon. Hated using it, hated installing it, hated everything about it, but it was what we had at the time. And then if you remember the Dexcom 7 and the 7 Plus, I actually still have one of those in my little mini diabetes museum. And these had like an error rate of 20%, so not great, but it was the start of personal use. And then now we have the CGMs that can communicate with our cell phones. So now we're going to go over the FDA approved devices. There are other options out there. There's the DIY and looping, and I'm not going to cover that in this presentation. I'd be happy to answer questions on a one-on-one level and cover any of that later, but we just don't have the time to cover all of those today. So we're going to go through the FDA approved devices. First, the insulin pumps, First, the insulin pumps. We have 3 main insulin pumps on the market in the US right now. We've got the Omnipod Dash, we have the Tandem Basal IQ or Control IQ, and they're both being shipped out and used, I think, equivalently. I do many pump trainings a week, and I'm still seeing a lot of Basal IQs. Medtronic's 670G, and they're soon to be upping to the 770G. So I've created this chart for you so you can see the communication, what they each communicate with, what apps they communicate with, how you get your data, And so you can compare them back and forth. One of the interesting things is Medtronic is moving from the Contour Next, and they're going to the AccuCheck meter. So I thought that was interesting. But remember too, the Medtronic system does have a CGM with it, but it still requires blood glucose finger sticks. So I wanted to outline the difference between Tandem Basal IQ and Control IQ. So Basal IQ means that the Tandem communicates with the Dexcom G6, and it communicates only in the form that if it predicts that the person's blood sugar is going to go below 80 within 30 minutes, it will suspend basal delivery for a short period of time until the trend arrow changes direction. So it may be 5 minutes, it may be 30 minutes, it may be up to 2 hours. It can suspend basal delivery. It can't add basal delivery, it can only suspend it. And Control IQ is probably the most technologically advanced system we have on the market right now. And Control IQ can suspend basal delivery under the same parameters, but it can also add basal delivery, and it can do microboluses to help correct highs. One of the questions I get about this product a lot is, does that mean I don't have to enter anything into the pump because it's already going to correct my highs? And we know with the Medtronic 670G and with other hybrid closed loops, and I really emphasize the word hybrid, because I think in the sales pitch of these products and in the media blasts and in general conversation with other T1Ds, people forget that word hybrid and they sort of drop it and they call it closed loop systems, and they're not closed loop systems. These systems require you to enter information, and all three of these products require the same information. They require you to announce when you're going to eat in terms of grams of carbs, and they require a current blood sugar or sensor glucose number. So even the Tandem Control IQ requires that. The benefit of the Control IQ, though, is that if you are running high still after a meal, it can microbolus you, but it only microboluses 60% of your usual correction down to 150. So it doesn't give you a full correction, and it frustrates a lot of people because they think that it should. So I just wanted to outline the two different parts to that. We're going to look at the data view on how you can see your information. Most of them have apps now. In fact, the 670G doesn't have an app, but the 770G will have a viewing app. I want to explain about your phone use and your insulin pumps and insulin delivery devices in general. People ask me all the time, why do they have these viewing apps? Why can't you just take your phone and press the buttons on your phone and it delivers your insulin for you? Why is it just a viewing app? And the short answer is that the FDA is the one that approves medical devices, and the FCC approves devices for communication. And the FDA and the FCC don't play in the sandbox together at all. The FCC does not want any form of delivery of a drug that can kill you on a phone that can be hacked or any, and I appreciate that, and I think you would appreciate that as well. But I think the explanation is really important to know why they don't do that. It doesn't mean they never will, but it's the reason why they don't do it now. Moving down to the bolus dosing, you can see the different pumps and how they can do increments of basal delivery. And thinking about our pediatric population, this can be a pretty important thing because a 0.05 and a 0.001 are two wide ranges of bolus delivery. I think there's a chat feature available with the Zoom meeting we're doing. And if it is open, go ahead and put your questions into the chat feature, and I'll get to the questions at the very end. I would like to have some input on other people's experiences with the different products. There are some, this is just sort of the specs of the products, but there are some other things that are more real life and experience of people input that I would like to have for the discussion we're having today. So continuing on with our pumps, this talks to you about how they attach to the body. The Omnipod pods are fantastic. They stick directly to the body. There's no fill tubing, and so you don't waste insulin filling the tube. It does carry 200 units. I don't have that on here, but it does hold only 200 units. So if you use a lot of insulin, you'll be changing your pod before the 72-hour time is up. But also, if you use a very small amount of insulin, and that's the truth for all of these products, you still have to have a minimum fill. I don't, off the top of my head, remember the minimum fill for Medtronic. I know that the Tandem requires you to have 50 units in the cartridge, but you really should fill it to about 100 to 120 units to make it happy. In the Omnipod, but it can hold 300 units, and Medtronic can hold 300 units as well. So both of those products can hold more insulin. I get a lot of questions about water, you know, showers, water skiing, paddleboarding, swimming. Is it waterproof? So that's the data down there. So I get asked a lot of times, what is your favorite insulin pump? And I encourage you to ask your providers this question, because it's kind of a trick question. It's not a trick question when I'm being asked, because I think that people really do want to know, what is my favorite insulin pump? But the answer that I give all the time is adult diapers. And then I just look at their face because they have no idea what I'm talking about. So the answer to what is my favorite insulin pump just depends. It depends on a lot of different factors. And I would, as a healthcare provider and a pump specialist, I would be very clear to tell you, I don't have a favorite insulin pump. It's not my diabetes. It's not my decision. It's your decision. It's the decision based on knowledge and education and usability and some of the parameters that we discussed together. It's based on that, and I'm here to support you on that. And I urge you to talk to your providers the same way. Ask them what their favorite insulin pump is. And if they give you an answer, it really means that they are showing bias towards one product, and you deserve more information than just that. It might mean that they don't know the other products, and that's not their favorite insulin pump. Might not be the favorite product for you or the best product for you. So have somebody objectively go over the features and the limitations. There's limitations on all of them, and I have no problem ripping them apart and telling you what I wish was better and why this is frustrating or why this is really good. But in the end, it's your insurance, what they're going to cover, and it's your diabetes, it's your external pancreas. So you make that decision. So some of the things that we do look at are those features. We play around with the pumps a lot. I call it a petting zoo. Just let people really physically touch the pump, feel it, and possibly put saline in it and apply it for like a little bit of a trial if they want. Visibility is an issue. Dexterity is an issue. As advanced technology as the Tandem pump is, and it's a fantastic algorithm, the dexterity that it takes to fill the cartridges and fill the tubing, it can be frustrating for many. So that's one of the things that it's nice to know. Lifestyle, people's lifestyle, what they do and how they manage their pump, insurance coverage, and at the end of the day, what kind of education and support are you going to get for your pump? If you get a brand new pump, which by the way, they're as expensive as a used car, even if you're not paying it, your insurance is. So what kind of education and support are you getting? What kind of products is the company, are they coming out with later? Omnipod Dash is a fantastic product, but they have the Omnipod Horizon coming out, which is going to communicate with Dexcom and be similar to the Tandem Basal IQ. So what are the things that you consider when you're looking for an insulin delivery system? We're going to move into CGMs and CGM comparison chart. We've got 4 CGMs on the market right now. Kind of four big products. We've got the Freestyle Libre, we've got the Libre 2 now. So it's the one that's like the size of a quarter. It's fairly inexpensive. It's not continuous. You do have to wave, we call it the receiver or the wand. You have to be interactive with it in order to wave that so that you can pick up the information. And that's kind of a thing that is something that people like to do a lot when they first get it, and then they forget their receiver or they haven't downloaded the app and they just don't do it as much. And if you don't wave that every 8 hours, then you lose that information. I believe the Libre 2 has improved that and it's more continuous. The Dexcom G6, it's got 3 parts to it. The transmitter, which I don't know, it's as a diabetes educator, it's frustrating when I'm on the phone with somebody because with the 3 parts, people don't really remember the name for all of them. So they'll tell me my transmitter went out, and the transmitter lasts 90 days. And that's the little gray piece, and that's the part that has the brains and the Bluetooth of everything. And they're really hard to get, and so they'll say their transmitter ran out, but they have a whole box of 2 more or something, and they really meant their sensor. So and the receiver. So the receiver can be your cell phone as well. So the Dexcom G6 is probably in the type 1 community the one that's used most. It's got the alerts and the alarms that people like. It can be frustrating when people set those way too narrow, thinking that it's designed to keep them in control. It's a tool to help you stay in control or stay in range, but it can be abusive if the alarms and the alerts are turned on. If it says that your repeat is never, it means it's going to repeat every 5 minutes. So I do go over people's Dexcom settings at every visit just to make sure that they're livable for that person, because a lot of times they don't know that that's why it's beeping so much. The Eversense is the one that is surgically implanted in the back of the arm, the upper arm. That one is a 90-day sensor, and you still do have to check your blood sugar twice a day to calibrate. And then we have the Medtronic Guardian, and I believe they're on the G3 now. And that is they have a standalone sensor that works with an app. And the shape of the Guardian hasn't changed from the other sensors that they've had, the previous sensors, the N-Lite, and it's the same sort of clamshell shape of the sensor, which I was a little bit disappointed with, because the shape, I think, has something to do with how it wiggles around a little bit and can cause, anytime your sensor moves around and wiggles around, that's when it can cause some issues below the skin surface with the interstitial fluid. So the alerts and the alarms, we have those customizable in many of the products, but not for the Libre. The Libre 2 does have an optional ability to turn alarms on now. I haven't played with it yet, so I can't really give objective feedback yet, but I shall within a week. The data that you view on your sensor, let me back up just for a little second and explain to people that sensor glucose is not the same thing as blood glucose. Sensor glucose, your sensor never touches blood. It's only touching interstitial fluid underneath your skin. So it does an electron transport algorithm of determining what your blood glucose would be. And it's fairly accurate. In fact, most of the sensors on the market now are more accurate than glucose meters. So sensor glucose gives you data from 5 minutes ago. There's a lag time in the data. That's why the arrows become more important, because it gives you more information on where you are right now. Blood glucose meters are obviously blood, and it tells you exactly where you're at right now in terms of your blood sugar, but you don't know the direction you're going. And the error rate in the blood glucose meters is higher than in the sensors. So if you're calibrating a product like the new products, and you're thinking you have to calibrate because it's way off, I would urge you to go ahead and use the blood glucose value if you want to for dosing recommendations, if you don't trust your sensor, but don't calibrate your sensor. Just let it catch up, because it's you can actually confuse it more by trying to give it a number that's out of the range. So it's a little education piece there. So looking back at our sensors, we look at the finger stick requirements. And this is kind of an interesting thing because, you know, with a sensor, where we are with technology now, you would think you wouldn't have to poke your finger at all if it's a sensor. We've gotten that demanding, and as we should. We've got our G6s that don't require, the factory calibration is so tight that, like I said, if you do calibrate it, you actually pull it out of range more than anything. And same thing with the Abbott, who their error rate, or MARD it's called, has narrowed even more so. So almost everybody is under the 10% error rate now, and glucose meters are 15 to 20%. So the duration of use of the sensor, obviously the Abbott Libre is the easiest one to wear. It's thin, it's the size of a quarter, and you can wear it for, there's the new 14-day Libre. The G6 is a 10-day. Actually, the sensor would last longer in probably all of these. All of the companies have done data for longer days, but one of the deciding factors is the adhesive. It's just really hard. You guys all know that sensors fall off, and adhesive, people are allergic to adhesives. So it's the only one that you don't have this issue with is the Eversense. So you have the implanted sensor, but you still do have a transmitter patch over the top that's got an adhesive to it. And you have to charge that transmitter every day. The Medtronic is still a 7-day sensor, and the transmitter battery needs to be charged about once a week. People that are on that system or that sensor are used to doing that. The Dexcom transmitter does not need to be charged. Body attachment, how to attach it to your body. Obviously the Eversense is the hardest one to attach because you need a surgical procedure to do that. It's not a terrible procedure. It's a cut through the arm, the back of the arm muscle, and then this little matchstick size sensor gets placed in there. Then after 90 days, you have to get it removed and put through the other arm if you want. And they're trying to get 180-day indication for that instead of 90-day. It's had a 180-day indication in Europe for about 2 years now, and not in the US. So the Medtronic sensor requires a substantial amount of tape. There's a technique to that. So if you know the technique and how to tape, or different techniques, then you probably have it down. But that process hasn't changed. And that's what the CGMs look like. You can see the matchstick size Eversense. So we've kind of come through this full cycle of injection, syringe injection, regular insulin, and Humulin N, and all these kind of cloudy insulins. And we got to insulin pens, and then we got to insulin pumps, and now we have pumps with CGM, and we have smart pens, and then the last picture I showed you is some of the DIY looping techniques that are not FDA approved and require a substantial amount of knowledge, and you've got to really want to live in your diabetes quite a bit. So that's an option, and there are support groups for that. They're not FDA approved though. So I get this question, what if I don't want to go on a pump, or what if I want to take a pump holiday? Nobody should have to go on a pump. They're not required. They're not necessary for your diabetes. If you don't want to go on a pump, I really want to make sure that people, if they make a decision not to go on a pump, they're getting the right information. And they know that sometimes people think that a pump is surgically implanted into the body. They think that they don't want anything attached to them, or they don't want to wear. And those are, the last one is a valid concern. The first one is not valid. It's not surgically implanted into the body. But if you have all the information and you're able to really look at pumps and understand how they deliver insulin, and you still don't want to go on a pump, you don't have to go on a pump. Nobody has to do it. But if you are on a pump or if you're not on a pump and you want a technique to help you dose your insulin, then the answer to that is SIP, a smart insulin pen. And also, if you are on a pump, I highly encourage people to still get a smart insulin pen, because technology is technology. If something happens and your pump's not working, your smart insulin pen can actually be programmed much like your pump, and you can slip right into pen injections that do the same kind of calculations. And we shall cover that. So there's going to be a lot of pens coming out on the market. Well, maybe not a lot, 2 or 3 coming out on the market that have Bluetooth capability to apps, but they're not smart insulin pens. So I want to make sure that consumers understand what is a smart insulin pen. There's currently one on the market right now from Companion Medical called the InPen. And Companion Medical just recently combined with Medtronic. So Medtronic is going to, for now on, be in charge of the InPen. So the InPen has a Bluetooth capability to an app, and you can program the app with your carb ratio, your correction factors, your targets. It will keep track of your active insulin, or also known as your insulin on board. So it can help prevent you from stacking insulin doses, which is a common thing if you're on multiple daily injections, just not really remembering. Who wants to remember the action curve and the pharmacokinetics of Humalog, and when I last took my Humalog, and should I take more, and my direction arrows are going up, all that kind of stuff. So if you're on MDI, you can program these things, or have your educator or your provider help you program it. It actually requires a prescription for them to program it. And it can communicate with Dexcom right now, or Bluetooth blood glucose meters. So I imagine that being owned by Medtronic, that something in that situation is going to change. And I'm not really sure how they're going to do that. Your InPen requires the same information a pump requires. It wants to know what is your sensor glucose and how many grams of carbs are you going to eat. Now, if you're working with a diabetes educator who also happens to be a registered dietitian, you can get some help on dosing if you're on a different type of a diet, if you're on a very low carb diet, if you're on a keto diet, if you're on a paleo diet, because the human body will create glucose out of whatever you eat. It creates glucose from carbs at a nearly 100% efficiency, and that's why we dose to carbs. But in absence of carbs, or too low of carbs, you're forcing your protein to convert to glucose. And so there's a way that we teach people how to dose to that, and when to do it and when not to do it. So I'll talk a little bit more about that kind of service. Your InPen also will give you notifications and reminders to take your long-acting insulin, and if you want to, you can program it to remind you that you didn't take any insulin from maybe 11 a.m. to 1 p.m. Did you forget your lunch dose? So some pumps do this as well. It's got half-unit dosing, which is really nice, because many of your basic insulin pens are 1 unit. You're dedicated to that 1 unit, so it's nice to know that you can do a half unit. And it works with Humalog, Novolog, or Fiasp. And you get objective data. This is what makes it a smart insulin pen, is that you get the data, which is really nice. You can, from your phone, you can send it to your healthcare provider. You can pull up your own reports. But it knows the difference between a dose and a priming dose, so that's kind of nice as well. But it'll tell you if you forgot to take your injection. Even if you don't have the notifications on, you can look at the data and you can tell that you did not take your injection, or you did take it, or you overrode the bolus advice. And when you do that and why you did that, there's usually a reason for it. So the data is amazing. Speaking of data, sorry, I don't know if any of you guys are Star Trek fans, but I thought I would throw that in. We also have diabetes management apps, and I'm hoping that people on the program today, or that can communicate with me afterwards, that you share with me the apps that you like as well. And I'm not talking about the apps that already communicate with your sensors and your pumps, because those kind of were included in with the products. But the other apps that I see people using a lot, Diabetes M is a pretty sophisticated app. It it takes quite a bit to program that if you know what you're doing. But I really do like it. I like the algorithm that it uses for bolus advice, and also for correcting lows, grams of carbs to correct lows. It's really helpful. My Sugar is an app that was developed quite a while ago, and they sort of evolved, and I believe they combined with Roche, and they're with that company now. Glucose Buddy we've used for years. Calorie King has the best database, the biggest and most accurate database of nutrition information. They use I believe it's the USDA, I might be saying that wrong. It's the biggest database that we have for accurate information on nutrition. It also has information on restaurant foods. I think this is the go-to app for looking up nutrition advice or information. Lose It tends to, Lose It and Fat Secret allows people to put in their own information from products, and it saves that information, and it's not always accurate. So I've looked things up that were way off because they allow users to add information to it that's not accurate. So I do like Calorie King. Fooducate is a really fun app to use, and it can give you nutrition information on products, but it also gives it a grade. So it lets you know the quality of the product, and it tells you why it gave it the grade that it did. And I don't always agree with the grades that it gives it, but I do understand why they're doing it. And it's pretty close. So I do like that app. And then one for carb counting that people forget all the time is Siri and Hey Google and Alexa. I show people this in the office all the time. They say, I don't carb count. I don't know how to carb count. I don't know how many carbs are in this. So we just ask Siri and ask Google and ask Alexa. And by the way, you can connect your Dexcom to Alexa as well, and you can ask Alexa what your blood sugar is. So that's kind of fun if you want to be creepy like that, but some people do. So I'd like to know what some of your favorite apps are, and teach me some of your tricks that you guys have. Here's some services. These are diabetes services that are new, that are out there, that are actually pretty amazing. Steady Health is the first 100% virtual endocrinologist, endocrinology and diabetes support. Look them up, Steady Health. I think they're out of California, but they're just breaking into the Washington state market recently. So I'm looking forward to working with them a little bit more. Alto Pharmacy is a app-based pharmacy that is in Bellevue, and it will deliver your medications on the same day or the next day. I'm really excited to have this company. They're kind of a startup company out of California. They've been there for about 5 years, and they just opened up the Seattle market, and it's the extensive Seattle market. So it's, I think, as far north as Linwood and as far south as south of Tacoma. But it's going to be a fantastic thing. You have the app, you enter in your prescription, and also for your providers, the thing that I like about this is that if we're looking for a medication or a certain kind of insulin for a patient, we can enter the information, and they will do all of the insurance in the background. They'll do all the prior authorizations that we need. And I believe they're also going to be doing devices, or they are doing devices as well, meaning sensors, pumps, and that kind of thing. So pay attention to Alto. I think that's going to be a great company. Other companies like Diathrive, you can get subscription to inexpensive glucose testing strips that they don't mandate how many test strips you use. One Drop does the same. Dario, I think, is still around. So if there's more, let me know. So speaking of data, this was actually the data I was talking about, not Star Trek data. The data that we get from devices, I think, has changed the care of people with diabetes. I think that prior to having data, or having data that you can't read, it leads into a patient visit that's more interrogative than supportive. You know, we're looking at blood glucose logs and asking people, you know, did you test your blood sugar? We don't say that in my clinic. We ask, you know, how often they check, because it's data. It's not a test. You're not testing whether you're a good human being or not. We just ask, have you checked your blood sugar? When do you check your blood sugar? But the use of this data already tells us when all that's happening. We don't have to ask these questions. We don't have to interrogate people and say, you know, well, what on earth did you do last night? What did you do at this? You know, we look at the trends, we look at the numbers, and if we have the critical clinical eye, we'll be able to ask the right questions. And if we're doing our job correctly, we'll be able to teach you what we're looking at. And I do that frequently. I'll turn the computer screen around or share my screen if it's a virtual appointment and show you the clarity report, and I will guide you through what I'm looking at and what I'm thinking is going on. And then usually that input from the user will be able to say, well, you know, don't, I'm afraid of lows, so I go to bed with higher blood sugars. And so that kind of that personal part of their care comes out, and we know how we can help them. So the data you get from these products can be frightening because you feel like it's a grade report, but it's really not. It really just tells us, it guides us and tells us how can we help you more. So this is kind of what the connections look like. And this, it's interesting because when you come into a clinic, you know what products you're on. You're on 1 or 2 products and they communicate with each other, but we have a smattering of people coming from all over the place on this product and that product, and it has to be uploaded by this program or this program or that program. And so this communicates with this, and in our minds, as care providers, we see the connections like this, but in my specific mind, I see it like that. So that's how everything is connected. So when you do take your, you're going to your appointment, whether it's with your diabetes educator or with your physician, this is kind of like what I would like to guide you on what you should expect from uploads and downloads. You should get an assessment of the settings. People's insulin use changes for many, many reasons. It changes when weight changes. It changes with the season. Believe it or not, insulin use changes a lot with the season. In the Seattle area, when it's daylight till 10 p.m. in the summer, people are out and about more. Maybe not so much in pandemic times, but they are out. They're moving a lot more usually. And in the wintertime, when we have far less sunshine, people tend to be hunkered down a little bit more, and then they have sort of isolated times of exercise. So the pump settings do change. They change with whether you're pregnant or not, activity level. If you're an athlete, they train whether you're in your training season or whether you're in your event season. So make sure that your settings are being assessed properly, and that people that you are talking to know how to assess those settings, and they're not starting your product on what I call factory settings. Make sure they're doing calculations and that they are explaining it to you. They're going to also assess the information that's put into the pump. So first we want to know, is the pump working for you? And the second thing we want to know, are you working for the pump or SmartPen too? Are you putting in the information? I had a guy yesterday who I looked at his pump upload, and he was putting in, he's got like a favorite number of carbs. He was putting in 25 grams of carbs almost all the time. And if he wasn't doing 25, he was doing 40. But he eats different foods all the time, but those were his favorite numbers. And so the pump is going to be frustrating, and it's going to be off because it only does as good as the information you put into it. You don't have to be an exact carb counter for any of these products, and that's kind of a misconception. You want to do the best you can, and you want to put information into the pump the best you can, but not the common guesses. There's better ways of getting better information. You should also have the expectations of your product. What do you want it to do? What did they tell you it would do? And what does it actually do? That's a really heavy, heavy statement, because there are heavy sales in diabetes pumps and CGMs, and everybody wants to believe the next best thing is that much better. So having that that critical discussion about what you expect it to do and what does it mean you're going to have to do to make that happen are things that should be on people's radar all the time. And then when we talk about potential adjustments, it looks like I spelled the word adjustment wrong. I will adjust that later. But we're talking about adjusting your pump, and we're talking about therapy adjustments and possibly behavior adjustments. So maybe it's pre-bolusing, you know, maybe that's something that you can do a little bit more frequently, or and if you pre-bolus, or at least not after you eat, an hour after you eat, then maybe the data will be better and we don't have to change the settings. You shouldn't have to change the settings every time you go into your doctor. It should be therapy setting adjustment or behavior adjustments, and sometimes both, but those discussions have to happen. Better the info, the better the results. Here's a little bit of information on how to be a team. The healthcare provider should be giving you expectations of how to upload, give you directions for uploading, should assess your uploads, should discuss the data with you, and should discuss therapeutic and behavior changes. If you have a provider that reaches their hand out and you hand them your pump and they start hitting buttons and change your rates and change something without any other information, I would really ask them a little bit more and figure out what they're changing, and ask them if you could please change that or teach you how to change it. It is your pancreas, so learn a little bit more about that, and make sure that they're really assessing it and they're not just changing a basal rate, because that's the first thing they think of. It really could be a correction factor. So on the patient end, understand your upload instructions on how to upload. Pre-upload if you can, because it takes so much time if you are coming into clinic or we're on a virtual appointment and there's no data there and it takes 15 minutes to get information. So try to be prepared. Be ready for open dialogue. Your partnership in discussing therapeutic decisions and behavioral decisions is incredibly helpful. It should be a collaboration. And then remember who the pancreas belongs to. That's your insulin pump. So be engaged in that. So who's on your team and what are their roles? You're on your team and you're the driver. You've got your physician. You should have a diabetes educator that you trust and that you like. You don't have to go to people that you don't trust and don't like. Your insurance covers other people. So make sure you shop around for the best person that takes care of you and your diabetes, or your child or your loved one. We also have care providers and teachers and friends in the T1D community. We've got a lot of different people on our team. So if you are looking for a diabetes educator, make sure you look for one that's certified. Make sure you look for one that's objective on devices, and ask the million-dollar question of what is their favorite pump. And if they answer it very solidly, then you know they're not objective. They should not have a favorite pump. Even if they're wearing a pump, they should not say what that pump is. They should probably hem and haw and say, well, it really depends on what you want in a pump. So that's kind of a critical question. Are they supportive of you, or are they punitive? Do they have clinical assessment skills? Can they look at your information and your lifestyle and who you are as a person and how you use insulin, and help you fit diabetes into your life? Don't change your life because of diabetes. So they should be kind of finding skills for that. Are they encouraging? Are they educating? It is our job to educate, and we should give you information on, you know, all of the products out there, all of the medications out there, and talk to you about them and give you options, because that's actually what we educate the physicians too. We know a lot more about the products than they do. So we're educating them as well, and advocating. I forgot to put that in there. We definitely advocate for you. So here's a shameless plug on why you would want us on your team. We get to spend more time with you, up to an hour a visit. Your insurance covers us every year. It's a renewable benefit. It's actually a Washington state mandate that diabetes education is covered, and it's a part of national standards for diabetes care. So physicians should be, it should be an automatic referral. You may have had a bad experience with one, and that does happen. So if that is the situation, they're not all like that. I've had bad experiences with physicians as well. But your doctor needs us on the team too, because we're the ones that kind of decipher a lot of the information for them. So now I'm going to talk to you about the elephant in the room. And the elephant in the room is the fact that we're spending a lot of time and money and energy and resources on insulin delivery devices. And it's a double-edged sword. The technology is great, but the cynical part of me makes me think, why are all of our research dollars going towards this? Why is our money not going towards the cure? So that is the million-dollar question. I don't mean to cure the band, but kind of I do. But actually the cure to type 1 diabetes. I really wonder why more money isn't trying to find a cure, and we're just using a lot of devices. So we do support devices, and they are great, but we want a cure. So thank you, and salute. Salute is the Italian word that means to your health, and that is the name of my company, Salute Nutrition. It means cheers, it means to your health, and if you don't pronounce it salute and you pronounce it salute, then it means in your honor. So I'm going to stop my share. Hi, everyone. And that's it for today. Do we have any questions? I've got some chat in here. Let's see what we have. I have a wonky left contact, so I'm trying to read. Somebody says that the Dexcom G6 has been great for them, super accurate, alerts the spouse with alert settings, and when they're traveling for work, pre-COVID. And insurance coverage has been frustrating, though. Yes, insurance coverage can be a pain. We try so hard to get insurance coverage for all of these products, and we fight really hard. There's a lot of the prior auth processes are frustrating, but we know how important it is to keep pushing things through no matter what. I can't say enough about advocating. And also, if you do have some issues with insurance coverage, I highly recommend you contact the reps in the area, because they are brilliant at trying to find ways around this. So with Dexcom, it's either going to be Kim Morrison or Ronell down in the South Sound. So they're great. They're amazing people. We have somebody else saying, thank you for mentioning the role of the CDE outside the physician's office. It's not something I was aware of. Oh my gosh, we're amazing people. We love helping you guys out. We're certified diabetes, well, our name changed to Certified Diabetes Care Education Specialist is the mouthful that we are now. But yes, we actually educate physicians a lot. We help your doctors out when you're not there and you don't see what happens, and we say, hey, Dr. So-and-so, this patient would really benefit from being on Tresiba, and Dr. So-and-so says, what's Tresiba? Or we think that this person should be on this pump because it's covered by their insurance. We show them all the pumps and they like it, and they're like, we don't know anything about that pump. So we educate them a lot. So do you know anything about the launch of the G7? Oh, these are exciting questions. I had the CEO of Dexcom, Kevin Sayer, in my office it was pre-COVID, so it had to have been January or early February. And he came in to visit me, and just to see like what it's like in the trenches of diabetes care. And of course, I pummeled him with the G7 questions because we can't wait for G7. So he showed it to me. He showed me the G7, and I was like, can I take a picture? And he said, no, you can't do that. But so the G7 is going to be great because it's finally going to be a reusable applicator. Like, isn't that frustrating? All of the stuff we throw away, it makes you feel so bad. You're like, I already have this stupid disease. I'm trying to take care of myself, and I've got to remember this, and I've got to remember this, and now I'm making this pile of trash that I can't recycle, and it's horrible. So that big knobby G6 applicator that we have to throw away and can't recycle, it will be a reusable one, and the G7 is going to be smaller, and it is going to, so it's a different shape, it'll be smaller, and I believe it's going to be 14-day. So yeah, very exciting. Anything else down here? Caitlin said you rock, Jennifer. Hi, Caitlin, I miss you.
Jennifer, there are also 3 questions in the Q&A tab.
Oh, I have to go there too? I can't just
there are 3 right there.
where people say how thank you so much. So someone's trying to stall and go from the G4 to the G7. Ooh, that's a big jump, big jump. And not only that, we don't know how long it's going to take for the G7. So if you're happy with the G4, if you're happy and you know it, clap your hands and stay with the G4. They're not going to have any more sensors. They're not shipping any more sensors. So you're going to have to get them other ways, you know how we do things in the diabetes world. But the G6s can be successful if you have somebody that guides you through it. Be careful about that's the other thing, be careful about the T1D world, about what you hear and what you don't hear, because they're a great source, but it's also user, in the science world, we call it N sample of 1. If they're an N sample of 1, do you want the US government to create a coronavirus vaccine on 1 person? No, you want them testing it on 10,000 people. So you have to have a huge N sample to really pull in the information. So let's go to the Q&A. How can you figure out the insulin to carb ratio? Insulin to carb ratio is calculated based on your body weight and how your body uses insulin, and how you, it's a convoluted formula. So you should have somebody that's already started to help you. And if somebody told you your carb ratio is 15 and your correction factor is 50, I would put money on 90% of that is wrong. Those are easy numbers that people give each other, and they don't really work. So one thing I tell people to do is, for one whole day, it can be fun, you guys, this can be fun, it really can. Just eat food that has packages. I'm a registered dietitian, and I'm not telling you that this is a diet. I'm just telling you that if you eat food that comes out of a package that has known carb counts, and you're dosing to that, and you take pictures of all your food, then you are going to get closer to your carb ratio. And it's really kind of fun to do, because I can teach you how to look at all that. Make sure it's a day you don't exercise and you don't drink alcohol. So it's not a fun day, but it can be. Can you comment further on the issue of needing to calibrate CGMs with blood glucose readings, but blood glucometers having high error rates being inaccurate? How can you truly know your blood glucose reading is accurate? And are there any industry trends that make them more accurate? So CGMs on the market are the most accurate, as long as you understand the trend arrows and the lag time. The Contour Next glucose meter is the most accurate meter on the market right now. And you just have to realize that there is an error rate in there. So if it says your blood sugar is 120, it's somewhere between 100 and 140. And it's always been that way. Nobody ever told you that. It's just always been somewhere in that area. That's why CGM with trend arrows is a lot more important to you, because if your CGM says that your blood sugar is 110 and you have an arrow up, but your blood glucose meter says your blood sugar is 140, then they're really actually saying about the same thing. So if you constantly calibrate your CGM on a meter that is less accurate, you're just messing up the internal calibration on the G7. I mean, on the G6, sorry, G7's not out yet. So that's a discussion. Next question, any advice on how we can try out the different pumps or CGM types? There's some things you can do. Some of the pump companies will allow you to do a saline trial. I know Omnipod is really happy to do a saline trial. You would still, use your whatever product you have, but you could wear the Omnipod pods and do a saline trial. You wouldn't really need, if you got a smart insulin pen, everyone should have one, by the way. They're only $35. They last for a year, so you wouldn't really need a trial on that. So the CGMs, what you can do is most insurance covers type 1 In Medicare even covers this. So if Medicare covers this, then most other insurances do. But they cover a procedure called professional CGM, and you can go in and get a professional you can actually do this once a month if you wanted to. Go into your provider, and if they have Dexcom Pro and Libre Pro, we have those. But if you have them, if they have them, then they can do a trial on you, and they can bill your insurance for that 10-day trial, so that you get to try it before you buy it. Any indication that Medtronic will give up on rechargeable batteries for their transmitter? I don't know what Medtronic is doing. I really thought that the 770G was going to have a different transmitter, and you wouldn't have to even poke your finger with a meter. So it's not. So no, I don't know. I can't really speak to that. So is there a pump type that has been better, that's been better for a 7-year-old? There's a couple of things you want to look at for small children. Omnipod is nice in that you can bolus from across the room. So you're not constantly invading the space of your 7-year-old child trying to say, let's bolus, let's do this. It's the kid can be a kid. You can be away from them, the other side of the room. You can monitor kind of just visually what they're eating, go ahead and count their carbs and enter that in there, and they don't need to know that that's what's happening. They don't have to carry their pump around. I like the delivery of the tandem pumps because it can do a lot more microscopic delivery for a small child. So there, I don't know, there's different ways of looking at that. Any other questions?
Veronica mentions in the chat that for a 7-year-old pump question that they have some direct experience with this and would be happy to discuss as well.
Perfect.
So
that's great.
Yeah, Mitchell's, if you'd like that more in-depth information.
Cool. I have 2 pump trainings to do today. So right after this, I get to put 2 people on their brand new first time ever pumpers. Pretty exciting. I always like that moment of first time being on a pump, and then they don't have to do the injections that they no longer want to do. But like I said, if somebody doesn't want to go on a pump, it's never a forced thing. I have 2 or 3 close friends in the JDRF world that just don't ever want to go on a pump. So they don't have to.
There was one other thing you asked for, favorite software resources, and someone commented Tidepool as a favorite.
Oh yeah, Tidepool. Yeah, that's one of the upload Gluco Tidepool. It's one that I like to use a lot as well because it communicates with so many different products, and I get very similar reports. You can't upload the Tandem Control IQ to Tidepool though. It has to go to T-Connect. I'm going to take my left contact out now. Thank you, everybody.
Thank you so much for joining us, Jennifer, and for your presentation. Always appreciate your knowledge and you sharing with us. So thank you.
Bye, everybody.